you so much to Global Arch and the invitation to be here with you today. These issues are really close to my heart, as most of the work I do is focused on trying to get evidence-based solutions out to people who are living with rheumatic heart disease and to develop new strategies for the future. So today, this panel is amazing. We are joined by three leaders of global organizations that are supporting truly innovative work in the global cardiovascular disease access space. For this panel, I'll introduce each person briefly and then after ask you to say 2 to 3 minutes. Let's keep it brief because we've got some great questions coming up on things that make your organization most impactful. So first we'll start with Blanca, who's joining us from Cardias AC. It's a foundation based in Mexico City that funds congenital heart disease care across Mexico. Cardias is really interesting because they partner with both public and private hospitals to provide care for patients. And the way they do that is to ensure that private hospitals have enough patients to maintain their surgical training while they offload some of the overcrowding that exists in the public hospitals. So Blanca, this is a really, really cool model that you have set up in Mexico. Can you briefly, couple minutes, try to tell us a little more about what your organization does in your own words?
Yes, thank you very much. Well, we try to mind the gaps in the care for congenital heart disease in Mexico by capacity building. And as you said, we partnered with a public hospital and a private hospital in Mexico. Public hospitals are really poorly funded. They have very low salaries for the medical team, not up-to-date infrastructure, but they have a lot of patients. And also they have experienced medical teams. In the other hand, the private hospitals have funds, have good salaries for the medical teams, infrastructures. And so these differences, we try to bring them together, as you said. We've been working 20 years, and it's been very inspiring and very, well, I don't know the word, but very exciting. We have been able to double the number of patients we bring to both programs. And as governments come and go, it is very good to have also the private hospital that is a more stable organization. Cardias does the coordination with both hospitals, and we also provide things that those hospitals don't do, like training for the medical teams, sometimes fund infrastructure, and also fund the database and funding for the, to have information to be able to assess our programs. We also do advocacy that these hospitals don't do because it's not their first goal, congenital heart disease. So the advocacy has to be done through our organization. So this is a collaborative program. Public hospital, private hospital, and NGOs, not only Cardias. We partner with other NGOs specialized in education for patients, funding, and data.
Awesome. That is a good overview. And I'd say inspiring was the right word that you were looking for there.
Yeah.
But we'll hear a little more about this in a minute. Let's turn it over to James. So James is representing the Hemsley Charitable Trust today. In addition to their groundbreaking work that they're known for around diabetes care and research, Hemsley has also extended its support to other non-communicable diseases, including initiatives to the NCDI Poverty Network, such as the Pen Plus program and the NCD Alliance. Their efforts have really helped to advance care and policy in low and middle income countries, with a particular focus on addressing healthcare inequities. James, can you expand a little bit on what Hemsley is doing, particularly in the cardiac disease space?
Yeah, thank you so much for having me. Hemsley Charitable Trust is a private philanthropy. As you said, one of our largest investment areas is in type 1 diabetes. We really entered that space acknowledging that chronic, severe, non-communicable diseases are underfunded and under-resourced in many ways. So when we thought about our strategy and how we improve access to care in low and middle income countries, we thought about that in a very pragmatic, practical way. What moves the needles with patients and providers, policymakers, is not a singular disease, but really thinking about integrated solutions. I think that's a theme we heard from a lot of other speakers during the session. So rather than investing in siloed efforts just on type 1 diabetes, our investments aim to reinforce existing health systems that support coordinated services and supply chains, and hopefully build lasting access to quality care through government-led systems. It's a long journey, but Helmsley has been very excited that over the last 10 years of first trying to understand how to develop a type 1 diabetes care model, we've evolved into supporting the Pen Plus model. We now support action in over 12 countries that provides integrated care for sickle cell disease, type 1 diabetes, and childhood heart diseases, including rheumatic and congenital heart disease. There's a number of other countries at various stages of implementation globally, and we've attracted a diverse coalition of partners with over 54 leading organizations, including ministries of health, the World Health Organization, including an endorsement from the WHO AFRA region, UNICEF, St. Jude's, Breakthrough T1D, the Scottish government, are just a list of the big names that we've attracted to advancing really a shared model directed at filling this gap. Helmsley is invested in making sure that we're really building on existing approaches rather than inventing something new. So the model Pen Plus comes from the idea of building on top of the WHO Pen model, which is more focused on cardiovascular diseases. How do we layer on chronic acute conditions like type 1 and childhood heart diseases? And that has been really important in terms of how we build this into existing policies and infrastructure, make sure that there's the capacity to be built on rather than reinventing the wheel. And I think the third piece I'll touch on briefly is that I think by working across multiple diseases, we've been able to really start to build a broader coalition of voices, especially community-based organizations and people living with these conditions to speak more collectively about the health system gap. Singularly, these diseases are relatively small issues in low middle income countries, but by working with a broader coalition, we've been able to mobilize a lot more attention and amplify voices to support each other in an effort to improve access for these conditions. So I'll pause there and look forward to chatting a bit more.
Thanks so much, James. That was a fantastic overview. The last panel member that I'll introduce today is Amanda, who I've had the pleasure of collaborating with over the last decade or so. And Amanda joins us from the Edwards Life Sciences Foundation, where among other programs, she leads the Every Heartbeat Matters program that partners with over 70 patient and cardiac-focused charitable partners around the world with an enormous goal of improving the lives of 2.5 million underserved structural heart disease patients just by the end of 2025. Amanda, can you give us a little bit more of an overview of your program?
Sure. So at a high level, our organization, Edwards Life Sciences, we are a medical technology company, and we focus on structural heart patients. And so when we think about not only caring for all those patients who do have access, we've really launched the centerpiece of our philanthropy to focus on those patients that don't have access. And we work with organizations like the ones that Andrea is leading and supporting to ultimately help detect the disease, structural heart disease, and that generally is rheumatic heart disease, congenital heart defects, as well as degenerative diseases in low and middle income countries. So we detect the disease, and then we support programs that treat it and also recover. And a really critical pillar in this is clinical education and making sure that its long-term viability is real. And I think a differentiator is we invest in all these partners. We don't just give them money. We also make sure that our technology is readily available for any physician that wants to do humanitarian care. And importantly, we bring all of these partners together. So physically, one time a year, we'll host a summit at our global headquarters, and having everyone come together and think, they bring their topics of interest. We listen to the successes of some. We also listen for the gaps in others. The goal is really to help fill those gaps and to leverage the strengths of all the different partners. And we've found that I'd say 90, if not more, % of these organizations are working together with at least 2, if not 3, 4, 5 other partners. So all of this together is the community that's learning and growing, and we find important touch points throughout the year, including this morning. We had a conference call we do quarterly. So Andrea is an important contributor to that.
Well, thanks so much, Amanda. So great job keeping those summaries brief, guys, because we have some really exciting questions, I think, that'll inform a lot of discussion today. So first, we'll start with Blanca. Blanca, when you're thinking about your program, how do you collaborate with patient and family organizations as well as the medical communities? And can you share any strategies that help you collaborate across these really multiple stakeholder groups within your context?
Yes, well, we are in our board, we have physicians, we have business people, and patient and family. So we are an organization with this model. Within our organizations, we have these groups. So in the board, each of the people that participate there have their own view in their experience. So we've been led by a physician, a cardiovascular surgeon, who gives his point of view on how a program should be in the part of the medical part. And then I am indeed a family, my daughter had congenital heart disease. So I also, as well as my business experience, I participate with my family experience as a mother of a CHD child. And in the hospitals we work with, there's also organizations of parents. So we participate also with them.
Thank you so much, Blanca. James, is that different in your organization? How do you guys consider the patient experience and patient participation in the work that you do?
Yeah, it's a great question. So first, I want to say that I think as a funder, we have a unique power differential. There's a reality that we're making decisions about which programs get funded, which are scaled, and what are the components and technical attributes of that work. And so I think it's something we're always striving to do better at, making sure that we're including and uplifting the voices of people with lived experience and how we form those strategies. I think we think about it in a couple ways. It's making sure that people with lived experience have the seat at the table in terms of how we're crafting policies or programs. But I think also thinking about how those people have paid time for their capacity, as well as the capacity to understand what are the decisions and background information that are going into those conversations, so everyone's on an equal playing field. We invest in a couple of different strategies that help that. So funding community-based organizations directly through groups like, in our case, the Type 1 Diabetes Community Fund. We work with groups like NCD Alliance to create coalitions and grassroots partnerships to bring together disease groups on the ground and make sure that they're informed in policymaking initiatives. And we also uplift voices. I'm thinking of Anu Gumanju, who's on the call today. I see who's a really powerful advocate for some of the Penn Plus work through the NCDI Poverty Network. I first heard her speak, and I'll admit I didn't know a lot about rheumatic heart disease at the time, but I think her voice really changed my perception of the program, where there's opportunities to improve access and strengthen connections from a person with lived experience in a clinical setting, and why that voice is relevant in terms of uplifting the needs of other communities. I think people with lived experience have a unique amount of passion for the cause. It's what's most relevant to their own lives, but they also, in many ways, are the experts of their own disease. They've had to think about it the most. They have to engage with the health system the most. And they ultimately know what are going to be the challenges or opportunities in terms of how to improve access to care. So I'll say we're trying, and we approach it in many different levels, both baked into wider projects like the Penn Plus work with NCDI Poverty Network, then also thinking about how we grow the capacity of community-based organizations and their networks to again build a movement for change.
Thanks so much, James. And you said so many things eloquently there, but I really liked your thought about ensuring that patients have a seat at the table, and really at every table is what you're saying, where decisions are being made that impact their lives and their care. Amanda, I know that patient support groups are dear to the heart of Every Heartbeat Matters as well. Do you want to speak a little bit about how EHM is focused on patients and patient voice?
Patient voice is really important. I will tell you, I think the most important thing as you are investing in these programs is to live it as a funder, to feel it, to walk the land with those who are struggling and facing this challenge so that you understand it. So I think listening to their needs, listening to the partners' needs, I think James said it very eloquently of making sure that you are, there is a bit of a, I don't like the word power, but it perhaps is true. So we really are wanting to be a champion for them, and I don't believe you can do that without literally walking side by side with them. So it's an important piece of my job, frankly, is to go out and be among the people, and I've done that with Dr. Beaton and other partners. It changes you, and it helps you bring that to the forefront and bring decision making, bring those thoughts to the table if they can't always be there. I really applaud, James, your idea of having the patient literally at a board table, and also appreciate that that's hard to do, especially when I look across 70 organizations, some at, globally at pretty sophisticated levels. How do you incorporate that? I really do find that listening and being on the ground as much as you can, that's how I am most effective.
Well, thank you so much for all that. I'm going to shift our conversation just a little bit because I know this has to be an issue across all these organizations. There are so many priorities and so many ways to create impact. Amanda, I'll put it back to you first because you've had to go last each time, but how does EHM think about how to guide and inform priorities? I know you get asked for funding applications, right, every year, and you're faced with deciding who to fund and what to fund. And how do you prioritize that within the organization to address gaps in care that you see globally?
Sure. For us, when we thought about what is this big vision, what do we want to stand for, what do we want to be investing in, we are not the huge, $1 billion Gates Foundation. So we feel like it's important to focus on helping patients now. I do believe research is an incredible space that you're really going to change for the long term. And for us, we want to feel it now. So I believe that clinical education is a critical piece and helping the patient. And so as we think about measuring that, we've had a very specific goal, and we do work side by side with the partners that we fund to come up with what's the way that we can have the greatest impact, and know that frankly we learn what is working and what isn't by really measuring all of our outcomes, and then honestly we look at the overall reporting or impact of each organization that's similar. So looking at all the screening programs and seeing how much does it cost, if you will, to get an ROI of a patient for a screening program or a clinical education program in detection or cardiac surgery. And we really try to think about what's the most cost-effective way to be delivering whatever part of that patient journey is. And then that also helps us inform decision-making in the future.
Oh, I like that answer a lot. It's almost impact through focus, right? You can't do everything. And so you have to make sure that your focus stays narrow for your organization to have impact. Blanca, do you think about this a little differently? Your organization is a little bit more focused on CHD, but what has guided your priorities as you've moved through your work?
Well, the priorities, as in everything, change with time. When we started at the public hospital, it was the most important priorities were infrastructure and people. So infrastructure, there was not PCICU. Then the medical team was not well trained. So we funded, as I said, people in infrastructure. When we moved to as a partner also with a private hospital, they had money for infrastructure and also for people. So we focused on information and data to convince them that they would have good results if they could assess progress and evaluate results for quality control. And now we're moving also in people, but not only to train our own medical team, but we have a program that it's called Cardopedia, that is a training program in Spanish that any people from the Spanish-speaking countries can affiliate, so we can have more impact in CHD in other countries and also in other hospitals in Mexico. So I think priorities change with time, and we also say, what can cardias do that others don't do? So you have to put value added to the money, and not only it's money, it has a lot of other things around it.
Yeah, Blanca, I really love that answer, because what I hear you saying too is that you're listening to the communities where you're working, and they're identifying needs and gaps that nobody else can fill, and you guys are coming in there to fill those needs. So I really applaud you for that. James, you obviously work with some really enormous global collaborations, and I think would have lots of opportunity to diversify and expand. How have you chosen some of those larger, especially as you've expanded into NCDs? How did you guys end up going with Penn Plus or with NCD Poverty Network?
Yeah, it's a great question, and I think I'll answer first by reflecting back on what Blanca shared. I think when Helmsley is thinking about its strategy, there is a lot we can do. I think Amanda touched on this as well. What we want to see from our partners, right, is a level of complementarity, so that our one investment here and our other investment there are really kind of creating a synergistic, multiplying effect to what we're doing. So we're often looking for partners that I think frankly work well together, understand their strengths and weaknesses, and are able to complement each other for a bigger gain. I will say that quite firmly, that no organization can do it all. No matter how many resources you have, even if you are those mega billion foundations, they need partners to come along as well. So I think we look for partners who are critically thinking about what is their logic model for change, their unique value add, and where others can join in to complement their weaknesses, and how do we layer them on together. I think, to give you an example, we know that partners like NCDI Poverty Network are really strong at doing implementation research, delivering implementation on the ground through service delivery pilots. They excel at working with national governments and creating policy changes, but they have some challenges in some areas. We know that supply chain strengthening, making sure that commodities and supplies are reaching people at a cheaper price, doing large-scale financing projects are maybe not necessarily their wheelhouse. So we look for partners that can fill those gaps. Similarly, we're sort of making sure that while they have a role in improving the overall patient advocacy experience, we know that that's not their main focus. So how do we think about other partners like NCD Alliance that can kind of mirror that coalition approach with kind of a broader advocacy capacity development initiative? So I think for the organizations that are kind of listening, really we look for partners that kind of break outside of their singular disease effort and kind of think about the broader ecosystem and where they fit in that, and then are clearly able to articulate their unique value add, and come to us with a strategy for change. It can be very compelling.
Thanks so much, James. We have a few minutes left today. We'll just turn to our last question. And Amanda, I'm going to start with you again, because you touched on this already, and I know there's a robust system for measurement that EHM has put into place, but how do you think about the effectiveness of the projects and programs you fund?
That is a good question. We, as you know, we have really specific goals. I have a mindset of measure what you want to achieve, right? So if you have big, bold aspirations, I think it's important to put smart goals around that. So timelines and, of course, specific goals. And that way we can help realize what is working and what is not working. And so for us, impact reporting is critical. It is not everything, right? So I do think there's the numbers side of this work, and that helps us make funding decisions in the future. There's also the heart part of this work, and where do we think there is authentic passion and enough influential mind share to make real change. I think that part is really critical also. So telling that story in a compelling way, and those that are in it for the reasons of bringing about change in life, change in humanity, I think that is a critical piece of this world that we all live in.
That's awesome. James, how do you guys approach measurement in your programs?
Yeah, I will admit maybe not as robust as maybe what you described at other partners, but I think we're thinking about it in a similar way. In some ways, we can look numerically at, how many patients we're reaching, what is our overall impact of improving outcomes within a certain cohort. But I think, as Amanda touched on, there are softer elements that we're thinking about in terms of where we can have maybe some interim outputs that we're thinking about in terms of where are we attracting co-funding to an initiative? Where's their buy-in from policymakers in country? Where is there sort of thought leadership, as Amanda said, that is kind of moving the needle forward? When we're operating in a really constrained resource environment, as we all are for non-communicable diseases, maybe increasingly so, I think it's really critical for us that we are seeing outcomes in that numerical way, like Amanda said, but also some of the interpersonal aspects of how you engage with others and bring others on board become really critical. And in some ways, that's a bit of an art that I will admit is a bit harder to measure and quantify in the same way.
Yeah, I love what I'm hearing, this combination of numbers, but also feeling and passion and commitment from your partners and direction and leadership. I think such hard things to measure. Blanca, do you have any final thoughts on this? How do you guys think about measuring the impact of your program and how that drives your strategy forward?
Well, as it has been said, it's very difficult to measure things, and also to do it like every year. It's good to measure past some time. There's a saying that says, if you measure what you do in 1 year, you think you have not walked enough. But if you measure what you have walked in 10 years, you see you have done a lot. And that's how we like to do it. But we were very fortunate to be part of the International Quality Improvement Collaborative, where we could measure our impact in the procedures or in the medical part. And for us, it is very important. And we measure volume, quality, and we also would like to measure the quality of life of the patients in a more long-term basis. So we now do it with the database, and I agree that it's not only the cold numbers, but also what you see in people. And it's also very difficult to measure advocacy. We do a lot of advocacy every year, organizing sport events, and it's difficult to measure if people are more aware now of congenital heart disease than before cardiac, but I could say that is real. More people know about the problem because of cardiac, but
Yeah,
that's measure.
Sorry, that's great, Blanca. And we can put the link for IQIC in the chat too. For those who don't know about it, that's the International Quality Improvement Collaborative for Congenital Heart Disease, led out of Kathy Jenkins' group at Boston, has been doing really cool work. There it is, really cool work to improve outcomes for children with congenital heart disease through surgical program strengthening around the world. So with that, guys, I think we're actually out of time. I know we could talk forever about these great organizations and how you're thinking about your work globally. I will thank all three of you for joining us today and for representing these organizations that do incredible work to improve access and care and outcomes for children living with congenital and acquired heart disease around the world. Thanks, Kate.
Thank you, Dr. Beaton.
Thank you. It was a pleasure.